immediately we sort of jumped into the literature. We realized that there was a huge amount of data out there on the Euclid lens, and to cut a long story short, we looked into a whole variety of databases, and we found 37 papers in English, so I could read them, and then Maria could tell me what they meant. And 37 papers where you had peer-reviewed studies on the Euclid lens. Now, of those 37, 12 actually had a control group. They weren't all randomized clinical trials, but you had control data in there. And amongst those 12, or was it 12 or 14? I've now forgotten. We've done things a couple of times, so the numbers get jumbled up. Anyway, so what we found is in those studies, because we had a control group, is that the lens on average slowed axial elongation by 0.18 millimeters in the first year, and over a 2-year period, it slowed axial elongation by 0.28 millimeters. So almost equivalent to the MySight lens, or depending on which number you use from their paper, equivalent to the 3-year data from the MySight lens. And that falls in pretty well with what you see elsewhere in the Ortho-K literature. People who've done other sort of more perhaps rigorous meta-analyses come up with similar numbers. The other thing that was interesting is when you looked at the other papers, which represented about 2/3 of the data, where they didn't have a control group, the patients in those studies were behaving pretty much the same way. So again, it added to our understanding of how the lens was working. Now, all but one of those papers we identified were done in East Asia. I think the vast majority were in China, a couple in Taiwan, maybe 1 or 2 in Japan. But there was the, I can never remember their, is it the CAMP study?
Yes.
Yeah, okay. So the Treehouse study that also had a retrospective data set on US patients. And oddly enough, when you look at those patients and compare them to a virtual control group, they again behave pretty much the same.
Another thing is we have so many new clinical studies available specifically about myopia management and about Ortho-K. But depending on the research background or the clinical background, the interpretation of those findings can be quite different. It's a little bit going tangent. For example, my interpretation of this apparent disagreement of low-dose atropine, higher concentration, lower concentration, which one is working, which one is not working, is very different compared to another peer practitioner. So, but that's a totally different story. What I'm trying to say is, it's not always that the results from the paper supports the conclusion, and I urge everybody to actually dig a little bit more into the actual data rather than simply reading the conclusion from the abstract. Would you agree?
Mm-hmm.
Yes, Maria.
Do we take questions? Or?
Yes,
All right,
absolutely.
you got a question there, Ave?
Yeah, I do. So, let's say there are some discussion points here, insecurities. Have we reached the ceiling of the efficacy of Ortho-K, or is there more to come? Can we do better than we're doing today?
I may have different answers than you do.
I think there are certain things which don't seem to make much of a difference. Like the recent paper on compression factors. I think, at least in my eyes, it's clear that if you're using a standard sort of fit-in technique, one size fits all without naming names, the higher myopes do better than the lower myopes because you've got more variation in corneal power in the post-Ortho-K. And you see that, I think, over and over again. It may not be applied to every patient. So we can certainly do better for our low myopes. The other thing, as I said before, we need to, I think, continually think about optic zone size, because if we can get more plus closer to the line, inside the pupil, that's, so I think, we've got a you've got a modality, particularly with the Euclid lens, that is very effective. I mean, it stands up against pretty much any other approach to slowing myopia progression. But I think there is room for improvement. But Maria may disagree.
I actually do agree. At least
Ooh.
Give me a
partially.
Oh, we got that. We got that.
I think in terms of the efficacy, I think of it as a three-tiered question. Number one, the onset of a myopia and the relative weight from the genetic influence versus the environmental influence. We know the earlier the onset of myopia, the harder it is to control, and they tend to have faster progression regardless of the modality of their treatment. That's just because the earlier the onset, the more genetically pre-programmed they have a thinner scleral structure to start with, so a smaller stress is likely to cause a stronger change. So number one factor is whether this kid is more of an environmentally induced myopia or a bias toward the genetic component. The second tier is different treatment modality. Currently, we do not have evidence showing that one patient is responding to treatment A, different overall modality, is gonna have the same response to a different modality. So maybe someone is better off with atropine or other pharmaceutical treatment, someone is better off with optical treatment. The third tier is within this same modality, do we have the maximized, optimized optical design? So that is what Mark is saying,
Right.
that we can optimize it if this is someone that's responding to that same treatment. So to answer your question, I don't think we can completely halt myopia, like up to 100% efficacy. If we're dealing with a 4-year-old with a -2 at the time we start the intervention, most likely this kid will continue to progress whatsoever. Versus if I'm dealing with a 10-year-old -1, I'm pretty confident with Ortho-K, with multifocal soft, or with atropine, we're gonna see pretty good, at least much better outcome. So I first want to evaluate the overall risk profile of the patient, then decide on whether the overall outcome based on the specific risk profile.
I don't think any of us would be here if we didn't think we could keep doing better.
I think there's room for, at least in some patients, but
Yeah.
that selection itself is progress, right?
Yeah, and I think if we're gonna really make significant inroads, we've not only gotta deal with progression, but also get serious about prevention, particularly in the higher risk patients. And obviously, got limited options there, but
Yeah,
we're
so
gonna have a big benefit.
one problem with the current research, at least I'm seeing the research effort is more focused on when or what to start as the beginning of the intervention. There hasn't been much research to identify who is a responder for what treatment. For example, if someone is under low-dose atropine is not getting the sufficient efficacy, is it because this patient is just not getting enough atropine absorbed into the posterior segment, or this patient is just simply not responding to atropine? At least in glaucoma treatment, if we're not getting sufficient IOP control, we don't just keep pushing the dosage. We want to consider switching from a beta blocker to a prostaglandin, adding a combination.
And then eventually you find out the patient's just non-compliant.
That's a factor.
No, I mean, if you talk to the glaucoma experts, if a patient isn't reaching target pressure, your most likely conclusion is they're not compliant. So anyway, I digress.
Coming
Well,
back
I mean, how else, going back to atropine, how else can you explain in the CHAMP study that 0.02% is less effective than 0.01%?
No, it's not, it's less effective. It's the 0.02% did not reach statistical significance. The p-value is not as strong as the 0.01%.
Okay.
But if you look at the mean and the standard deviation, the 0.02% still has a better mean than the 0.01%. It's just because the spread of the data is large enough that the p-value is not significant. Thank you. You asked the question.
It's fine.
But
Disclosure, consultant to Viluma. I do know the data.
Yeah, so coming back to Ortho-K, I think from an industry partner standpoint, we want to have the lenses that not only has like a better optical design, but also better consistency of how this back surface design can be translated on the front surface of the cornea. Right now, a common problem we're seeing is the same design applied to different patients, we're seeing totally different topographical changes. And so in the future, I'd like to see more of a consistency of this is what I designed and this is what I'm getting on the corneal surface. After all, Ortho-K patients, their optics is from the molded cornea, it's not from the lens itself. So yeah, so we want to see this better transferability of the back surface design onto the corneal surface.
I'll agree with that.
That would be great. Yeah.
But then patients' sleeping time is different. Some people sleep longer, and also the eyelid. Some people have tighter eyelids. Yes.
Yeah, so exactly what's causing the lack of specificity in the treatment is not very well understood. But sleeping time is actually probably not going to be a major factor. There has been studies published in Australia, Pauline Kahn and Helen Schwarbick's group in showing wearing the lenses after 2 hours versus after 6 hours. The treatment is actually not that different, at least for low to moderate myopia. But I agree, Ortho-K, one challenging part for Ortho-K is that you don't get to see exactly how it's working. You're dealing with this black box where you see the patient sitting up in your chair, but the patient is wearing the lenses in a supine position with the lid closed, with the REM sleep. The lens is actually moving under the upper lid, and so that's very different than fitting the scleral lens. You get what you see. So yeah, that can be another challenging component with Ortho-K.
Yeah, I think that's one of the things that we've tried very hard to do is bring more science to this, and certainly these two people are a big component to that. Is, you know, if you've been fitting lenses as long as I have, a lot of it was what happened yesterday, and I believe that would happen today, you know, because we didn't know. So bringing Ortho-K from 20 years of just usage and what we thought about it into truly a scientific model is really important, I think. We need to understand to each point.
And the other thing to remember is that, you know, the designs, at least we started off with, were designed to provide good vision in adults during the day rather than to slow progression of myopia. And even though those lenses have been around and approved for 20 years in the US, we haven't really come, I think, that far from those. And you know, if you look at the Manicon lens, I think it gives a really good optical surface, but it may not be as good as it perhaps could be in terms of slowing myopia. So, you know, so we're learning. And fortunately, I don't get my opinions tainted by seeing patients. So I just keep my head in the books. We got one more question at a risk of getting a 15-minute answer.
Or comments?
I think we'd, comment?
Comments?
When you decenter a lens, you introduce the plus within the pupillary area, but then the other part, the other opposing part, you're further away from the pupil.
Yeah, but if the plus, if you've got a centered lens, then the plus part may be outside the pupil, and by centering it. And all lenses, whether they're soft lenses or rigid lenses, do have a tendency to decenter, which for a single vision lens is no problem. Okay, so you put a single vision soft lens on the eye, not a problem. You put a soft multifocal on the eye, you've got huge variability in the amount of decentration, and that's gonna affect the performance. Rob Jacobs and I actually observed this 32 years ago when we were one of the first people to actually put a soft multifocal on the eye and then point a topographer at it, and they all decentered. And one of the things that explained was that lenses we thought would be pupil dependent weren't. Okay, so the old SIBA spectrum lens and the SIBA bisoft lens, which had sort of 2 or 3 millimeter central zones, they were pupil independent. Okay, and we measured these on an optical bench on my eye, and lenses decenter, period. Whether that's good or bad, we'll disagree, but it happens, and maybe it is slightly to our advantage.
I'd like to add another point about plus defocus. So we know plus defocus, at least in animal models, has been serving as a very potent stop signal for abnormal axial elongation. But at least from all of the clinical studies, especially with the recent novel spectacle designs, we know for sure that plus defocus is only one type of stop signals. From the lenses that actually reduce the retinal image contrast, for the lenses that actually, the micro lenslet in the spectacle design, even without the plus defocus, and instead they're adding higher order aberration, either a plus or minus spherical aberration. They're adding coma, they're adding SIL, so each of those micro lenslet is a cylindrical lens. And the most dramatic design is a hexagonal patterned lenses, but their micro lenslet is a -2. So the distance carrier is the patient's full distance prescription. The micro lenslets are the minus lenses, so they're technically creating a hyperopic defocus. But with all of these designs, they're all controlling myopia. And the Hori design, which is the hexagonal design with the +2 add and the -2 lens, they're controlling myopia almost to the same level. So now we know at least there are some other signals can also serve as the stop signal for abnormal axial elongation. And more of a generic or umbrella theory that can encompass or coherent with all of these would be, for all of these designs, as long as we can dampen the retinal's ability to pick up the go signal. The go signal is a relatively clear image. On top of that, a direction, or usually it's a hyperopic defocus or form deprivation, and to trigger the abnormal growth. And as long as we can dampen that ability to pick up the go signal, and it's actually serving as a stop signal, whether it's reducing contrast, or it's adding aberration, or it's just reducing the image quality, at least from the spectacle world, we're gonna see more and more clinical study results, and that's telling us plus defocus is not the only way of slowing down myopia. So I would be very interested in seeing more data coming out of the spectacle world. And maybe that's gonna help us in understanding what exactly is the retina decoding the stop and go signals. But when I was in optometry school, we used the analogy of the retina being the screen of a camera. But retina is much more evolved in picking up changes, whether it's the differences in color, differences in luminance, differences in contrast, or difference in defocus. But the retina is much capable of picking up the difference or the contrast or the changes, either on a spatial domain or on a temporal domain, much better than an absolute registration like the pixels of the camera screen. So maybe it's just the ability to enhance the retina's detecting of the changes. That's serving as a good stop signal. But I do have to say, at least in my chick animal work, the minus and the plus defocus does not work as like a simple linear pattern. It's more of enhancing the retinal's ability to detect that border or detect the changes.